Well, good morning. Greetings from Lucknow. It's a pleasure being with you, and thank you for listening to me. Uh, well, I'll introduce myself first. I'm a surgeon, and surgeons work with hand. They don't try to use their mind too much. But I was sent to take a master's in clinical epidemiology at the University of Pennsylvania. And so I am a surgeon, but a different type, a different breed. And let us come to the subject. I have retired as the founder director of AIMS Patna. I am basically an orthopedic surgeon who had said bye bye to mathematics after class 10. But the divorce was reversed when I was sent to University of Pennsylvania to do a master's in clinical epidemiology. Not only did I have to learn the difficult statistics and all those things, but I learned to enjoy them, and I found the learning very, very useful in publications, in getting research projects, in being able to talk my point of view on basis of evidence, and to get into promotions early and to get into very high posts. So now I think you too can do it, but let me try to increase your appetite by talking about study designs. Research studies are done to create knowledge and devise strategies to seek happiness, avoid pain, ignore the neutral. You see, all the time, all living beings are just doing this, seeking happiness, avoiding pain, and ignoring the neutral. So, any research proposal is judged on these grounds that it should do large good to large numbers safely in least costs. And of course, it should not be a duplication. It should address an unanswered question. Here, the event of interest is getting diseased, or cured, or disabled, or dying, or lost to follow up. So, a normal gets diseased, a diseased can get cured, disabled, die, or we don't know about him, lost to follow up. So, that's the model that you are studying. And there are transition rates to it. For example, 1,000 normal, amongst the 1,000 normal, 200 will get diseased in 1 year. Now that is the incidence rate of diseased or event of interest. And since the event of interest is negative, we don't want people to get diseased, therefore it is a red arrow. But the disease getting cured is of course a green arrow. So we want to promote the green and break the red. And therefore we have to study the risk factors or the factors that will accelerate or break the rate at which these transitions are occurring. So basically, first question that we want to answer is what is happening? And we want to answer it accurately. We do not want to have false positive and false negative results. So any study that helps you answer that question is called as diagnostic tests. Then we describe this is happening when, where, and in whom. Here again we are studying the event of interest only, and these studies are called as descriptive studies. Then we want to find out how and why. And as soon as that happens, these studies become cause-effect studies. Now the cause can be in series, A caused B, B caused C, C caused the effect that we are looking. Even if one of the things is absent, for example, if B is absent, the the chain will stop. For example, if there's an agent, it is spreading by, let us say, water to the host. If the if the what if the transmission is stopped, the disease will not happen. So these are called as essential causes. But if cause A, B, C, D are directly causing the problem, for example, if obesity is aggravating diabetes and eating sugar is also aggravating it, then they are causes where there is an add up or chance increases of the effect. So they are essential causes and non-essential causes that we want to study. And after studying this and knowing the impact on the event of interest of all significant causes with a lot of weight, we want to translate the information into a strategy which tells the answer of then what. Who will do what, when, where, how, with what resource to impact the event of interest so that pain is reduced, pleasure is enhanced, and that happens to a large number of people. So the first is what has occurred. Is the EOI present or absent? So these are the diagnostic strategy developing studies, and they aim to minimize the false positive and false negative. One of the tests we have to consider as a gold standard, which has zero false positive rate and in which we assume there is zero false positive and false negative rate. The other is a surrogate, which is cheaper, safer, less invasive, available to the last one in the queue. And many times it can be a collection of clinical symptoms and signs. So that surrogate, since it is cheaper, less invasive, more easily available, can get to the last one in the queue, is supposed to substitute the gold standard. So if the gold standard and surrogate are both yes and no, binomial variables, then the studies are called as validation studies. If the gold standard and surrogate are both giving results in numbers, then you plot a scatter plot on the x and y axis, you draw a trend line, and so that by this trend line you come to know as to what value of surrogate will correspond to what value of the gold standard. So the third component is that the gold standard is a yes-no variable and the surrogate is giving you readings. For example, fasting blood sugar, and you are trying to say diabetes yes or no. So fasting blood sugar ranging from 60 to 70, 70 to 80, 80 to 90, 90 to 100, 100 to 110, 110 to 120. So which is the best cutoff? So at each cutoff, you draw a 2 by 2 table, find out the true positive and false positive, and true negative and false negative, and try to determine the sensitivity and specificity at each cutoff. Then you choose the cutoff which will give you the largest sensitivity and specificity. This can also be done by what is called as a receiver operator characteristic curve. Then, after you have been able to accurately decide what is occurring, so that any Tom, Dick and Harry anywhere can say whether the effect of interest is, the event of interest is present or not. Then you have an accurate method of data collection. And then you try to find out the time, place and percent distribution of event of interest. So then, after the event of interest, which means time when, place where, person in whom the event of interest is occurring. Then you want to find out why is it occurring. So here in the descriptive studies, only the presence or absence of event of interest was recorded, but here both cause and effect are recorded in the particular patient or victim or the unit under consideration. Now the cause in medicine can be a etiological factor, the effect is disease. The cause can be a prognostic factor in a diseased person and the effect can be outcome. And the cause can be treatment or intervention in a community setting and the effect will be the result. So these are the common relations, cause-effect relations that you are studying in relation to healthcare. Now let us see this cause-effect study design. The first is that you take a cohort of study population randomly from the source population so that it is representative of the target population of sufficient sample size. You classify these persons into cause positive and cause negative. Let us say alcoholic or non-alcoholic. And then you follow them forward in time to compare the proportion affected in each group. For example, if the alcoholics developed 2% cirrhosis during a lifetime and the non-alcoholics developed 1%, then there is 2 times greater risk of cirrhosis, lifetime cirrhosis in alcoholic as compared to non-alcoholic. Now these studies are cohort or prospective studies. The collection of cohort can be historic also. For example, you can have a population having both the effect positive and effect negative and find out what proportions and retrospectively find out who had the cause or who did not have the cause and then reverse the direction and find out whether the effect was there or not. Such studies are called as historic or retrospective cohort studies. They are also called as nested case control studies. They are different from case control studies because in the case control studies you start from affected and not affected and go on to find out whether the risk factor was present or absent. But here, even though you have collected a affected and non-affected population, you are actually looking at the cause present or absent and then following it forward in time to find out whether the effect occurred or not. So these are called as nested case control studies. I hope you understood them. If you did not, we'll try to explain it again. So then in rare and remote outcomes, you have to have effect plus and effect minus cases. For example, if you want to find out how many patients of about 40 years developed cancer associated with smoking. So at 40 years, you collect, if the incidence of cancer in non-smoking is, let us say, 0.2%, then you will have to collect 100 cases to get to. And that may be so, and you'll have to follow these. Supposing they developed cancer in 10 years, so you have to follow these cases up for 10 years. So 100 cases to get 2 cases. Now supposing you have to get 30 at least, you multiply that, it becomes 1500. So 1500 patients were smokers and 1500 patients were non-smokers. That means you're following 3000 patients for 10 years. Therefore, remember this formula. In rare remote outcomes, you do case and you compare proportions of the risk factor in cases and matched controls. So these are case control studies. And when both cause effect are measured simultaneously in the same segment of time, they are called as cross-sectional studies. In all of the three, the cause plus minus is observed. You are not administering somebody to smoke. It is only observed. Therefore, all these three studies are called as observational studies. But when you try to find out the effect of treatment or an intervention strategy, then you are actually administering that cause. You are giving treatment A or treatment B. That means cause is administered by the researcher. So therefore, this becomes a great ethical responsibility. Informed consent has to be taken. It should be without lure or duress. You should absolutely be sure of doing no harm. Then you should ensure equity, which means you can't study a very costly drug on poor people and then use it only for rich people. Then you have to have justification for testing the new treatment against old. There must be a real doubt. The question must really be unanswered. Then you have to have a built-in plan to detect and manage the unexpected events during the treatment, including that if you get an unexpected event, you will stop the study till that is sorted out. And if in the interim analysis one treatment proves to be better, significantly better than the other, then there's no point in giving inferior treatment to the conservative, to the other group. That means then after the interim analysis, all the persons will get the better treatment. Then you must understand that there is a human risk which is involved in creation of this new knowledge. So there is a very important responsibility that this knowledge has to be used, its use has to be ensured by widely publicizing the result to ensure translation into policy and practice and also to avoid duplication. Now here, the most powerful way of allocating treatment A or treatment B is random allocation to the treatment groups over a sufficient sample size, because this random allocation will render all the groups that are being compared equal on all known or unknown explanations of difference in results, which are called as confounders. Therefore, randomized controlled trials are the best types of study to compare two treatments or many treatments, because they can take care of both known and unknown confounders. So I'll give you an example of confounding. For example, if there was a patient of intercondylar fracture and I was taking the round and I said that conservative treatment is better. So my senior resident said, no, sir, let's operate. So I went to the literature and I said that in conservative treatment, uh, 8 out of 20 patients did better. In operative treatment, only 4 out of 20 did better. Therefore, there's a 2 times greater chance of good result with conservative treatment. Let us do conservative. But my senior resident was also expecting a jolt. So he said, sir, conservative treatment did better because less displaced fractures were treated conservatively and more displaced fractures were treated operatively. Therefore, conservative treatment doing better is because they had lower grades of displacement. Now here, lower grade of displacement, grade 1 and 2 in conservative and grade 3 and 4 in operative, is the other explanation of why the conservative did better. And these types of things are called as confounders, and both known and unknown confounders are best controlled by randomized controlled trials. Then if the treatment is very costly and you simply can't do it, you are not getting a sufficient sample size, then many small randomized controlled trials, if they are similar, can be pooled to get a very large sample size, and larger the sample size, more the power of the microscope and more your power will be, more precise will be your estimation of the effect of difference. So sometimes when very large sufficient sample size randomized control trials are not possible, then you can do what is the combination of results of many randomized control trials, and these are called as meta-analysis. So then, to answer important questions which would guide practice or policy, some people have to do translational research. So did they throw their net wide, try to comprehensively look at the published and unpublished literature to answer that important question, critically appraise the quality of each paper in terms of internal validity, that means the result should apply to the study population, and external validity, that means the result should apply to the other population. They use the most effective, least costly, logistically available combination of strategies to achieve good to large numbers in a cost-effective manner available to the last man in the queue. So now, since they know the risk factors accelerating or braking, the good arrows, and the risk factors accelerating or braking the bad arrows, they are able to cost each strategy and see whether it can be available to the last one in the queue and choose the most cost-effective strategies which has a good outreach. And the combination of these strategies they document, and we can convert it into guidelines for practice or policy. And the important thing is that if you involve the decision makers also in such studies, so they own the conclusions that you draw, they will use those conclusions in the development of policy, plan, get approvals, execute the plan, monitor to detect and correct faults so that you have an optimized plan, and therefore you should ensure use when necessary and avoid duplicate research. So that's how you translate research, good research, into action. Now, example of this is that there are head load carriers There are women who are carrying head load, and because of that, we assume that they develop cervical neck pain. So we did this research, but then very soon we said yes, much larger proportion are having cervical neck pain. So we devised apparatus which would take off the weight from the head and transfer it to the back and the shoulders. And then we had to do a trial to confirm this. And all this was funded and supported by Ministry of Labour of the UP government, and therefore it was very easy to convince them to market the device and use it at work sites. So that's how you have to involve the decision makers very, very early. Now we'll give you an example of some effective research. So the AES, acute encephalitis syndrome and Japanese encephalitis, were involving 5,000 children per year in North India since 1994. 3,000 got disabled for life, 1,000 were dead, and the response by doctors and health managers and everyone was patchy. They were telling stories about this should be the cause, that should be the cause. There were lengthy discussions and even fights, but nothing serious was being done. So the response till 2013 was patchy, unplanned, and thus ineffective. So the AIIMS Patna, newborn AIIMS Patna in 2012, the Rajendra Prasad Research Center in Patna and the State Task Force of Bihar micro-mapped, now this is not max, it is micro-mapped the 2012 epidemic by filling data collection pro formas from the home of the patient using a mobile. Now this mobile transmitted the latitude and longitude information of the patients, and also the start of symptoms data so that we knew the date of onset. And all this was stored on an analyzable Excel file. The EpiInfo software program, which is a freeware from CDC Atlanta, was used to create a video of the pandemic, and it is actually videoed. I mean, these dots keep on appearing over time on a video, but this is the end snapshot of the video in this picture. Okay. By just this, can you make out how the epidemic spread? Okay, we've given you 5 seconds to try, and you can tell me who was able to detect the cause. Acute encephalitis, Japanese encephalitis are basically viral diseases which involve the brain and can cause a lot of disability and death. So I have given you enough time to see the diagram and find out. What you also can see is that the bigger dots means larger numbers there, and you can see a graph, and this first one is the Muzaffarpur epidemic, which is east of the Gandak, here somewhere, here, and the west one, west of the Gandak, is the Gorakhpur epidemic, which is that larger graph there. So we had this micro mapping, and let's see the observation. So you observe that the Saryu limits the southward spread of the epidemic. Can you see that line beyond which you cannot see, the southwest of which you cannot see the red dots? Conclusion: waterborne spread of an agent through fecal-oral route. Possibly an enterovirus carried in the intestine of carriers, estimated at being 5,000 per year. Given that 5,000 annual occurrences occur in northern India, the carriers must be at least 1,000 times that. Now, how are these carriers transmitting? They are using the north bank of Saryu water for open toilet, and that water carries the virus to the mouth of the downstream people who are using the water for bathing. Now, we thought that what to do. The important thing is that since the epidemic cannot cross the midstream of the river, we can use the midstream to stop it also. So what we did was that we called the chief minister and we presented this, and we said that let us ban open defecation and make toilets near the bank. He said, I am the chief minister of Bihar and this needs to be done in UP because it's from there that the virus is flowing down. So that was not a viable option. Then we said, well, we'll do a clean water campaign. We'll spread chlorine, we'll distribute chlorine tablets, teach people. So he said, okay, accepted, do it in Muzaffarpur. Then he suggested a third method of diverting the midstream to the north bank so that the fecal contamination is washed off. Well, he laughed, but he didn't accept this. So we did a clean water campaign in Muzaffar in 2013. In 2013, the cases were 1347. In 2014, there were only 64. So 2015 onwards, we saved 1283 cases per year in Muzaffarpur alone. If we give that the base incidence of the disease is 5,000 cases per year, we saved 4,762 cases of very serious problem causing death and disability of acute encephalitis syndrome for perpetuity. The model was used in UP. We presented it to Yogi ji, and now the epidemic is history. So, let me draw the idea that we used to wash the north bank of fecal contamination. I mean, that was a very novel idea. Doctors trying to think like engineers. So, you see, that's what you should be able to do. We'll go to a new file like this, and we'll make the river as thick as possible. Okay, so here's the river going like this, and here's a bridge. Bridge we'll make like this. So here is the bridge, and here are the pillars in the bridge. We suggested that we put diversions like this. We'll make the diversions a different color, like this. So what will happen to the stream? Stream that is flowing like this midstream, will now turn towards this side and clean the fecal contamination here. And it costs nothing. I mean, you just put a diversion which diverts the midstream. And as such, this midstream is not allowing the virus to spread from here. No. You can only go this way. and get into the mouth of somebody who's living in the North Bank. So this was the study, and this is the power of application of mind and being able to do even a simple thing like time, place, and person distribution before you move on to causality studies. Thank you.